Dr. Anna Radin, how are you?
I'm great. Thanks so much for having me.
Thank you for making the time, and thanks for putting up with my coffee-fueled insanity before we got rolling here. You work with St. Luke's. You specifically work in the suicide prevention specialty, and is that accurate?
Yeah, I work in the applied research division, and my team focuses really pretty exclusively on suicide prevention research.
This is a hyper-relevant topic for our country now in general. More localized, the Boise School District saw, I think, like 4 or 5 suicides of students within the district in a very short time frame. I believe it was like 12 months ago or 18 months ago. Horrible, right? And, it seems that since 2020 on, the tension and pressure on people has just been just overwhelming. Yeah. And figuring out how to not just prevent suicide, but uncover the underbelly of like, okay, but what's causing people to feel like this is the only option, right? Because we could, if somebody's looking at classic examples, very sadly, people jumping off the Golden Gate Bridge. And there were many examples of people rescuing people from that acute moment. In fact, I had a student who went to jump off the Golden Gate Bridge and somebody grabbed her. And she wrote her college entrance essay about this experience. And ultimately, yes, there was that acute event where somebody prevented her from ending her life, but then there was all of this work that came out of like, okay, but why were you there? Like what happened in that moment? And I think everybody can get behind the idea of like, okay, we should stop people from committing suicide. But then there's this effort of like, okay, but what's happening within this community or within this home or within this person that's driving them in that direction? Talk to me about suicide prevention.
Yeah. So there's kind of 2 different things you brought up, both of which are really, really important. One is understanding what's going on with people that's getting them to the place where they're considering suicide. The second is what can we do to help them once they get to that place or even before they get to that place. So a lot of our work is really focused on the second piece, which is what kinds of supports can we layer in for people that are already experiencing suicidal thoughts, and what can we do to prevent those thoughts even from beginning if we go further upstream with people in our communities? So
right, because the best suicide prevention is if nobody thinks suicide is a good idea.
100%.
Right, because we term suicide prevention of like stop somebody from jumping off the bridge, but it's like the better prevention was whatever happened in the first 14 or 15 years of this young girl's life. What was going on with her then?
Yeah, exactly. What can we do to get upstream? And then we want to also have those crisis resources in place for people so we can kind of attack both sides at the same time.
So talk to me about both of these layers.
Yeah, so suicide remains one of the leading causes of death in the United States, and it's one of the only leading causes of death that continues to rise. In Idaho specifically, our suicide rate is consistently one of the highest in the United States. This year, we're the 4th highest suicide rate in the U.S., and our suicide rates in certain age groups are even more escalated. So, for example, in our teenagers, our suicide rate in Idaho is 3.5 times higher than the national average. So those are pretty striking statistics. I think folks that live in this state, a lot of us have been touched by suicide in one way or another, and a lot of our communities have been really impacted by this issue. But we also know that there's a lot of support here for folks that are struggling, and a lot of support to do more. So that's why we're really excited about, we've got a couple of big things that we've already done in this space and a couple more that are coming up that I'm excited to talk about today.
Dude, hit me with it. Because one of the, I had the former president of the Farm Bureau on last year, almost around this time. I think it was March. And the conversation kind of went to acknowledging that within the agricultural community, like that is one of the most suicide prone, industries in the country because of the risk you're taking, because of the variability, because of the lack of control over markets or weather and things of that nature. Do you think just in identifying Idaho as like, okay, Idaho's top 5, consistently top 5 for suicide in the country, do you think part of it may also be that we have this prevailing industry that is suicide prone, like worldwide because of these things?
Yeah. Well, if we look at the other states that are high on that list of suicide rates, 8 of those 10, those top 10 are in the Intermountain West. So those are states that are culturally, geographically, economically similar to ours. So there are a couple things at play there. There are economic factors, like the industry that you're involved in.
Right.
Definitely agriculture has that potential for volatility that can be a risk factor. There's also things like social isolation that may be more common in certain communities. We know that rural areas of the United States face about 50% higher suicide rates than urban areas. We also know one of the big factors that contributes to death by suicide is access to lethal means. So states that have more access to firearms, states where medications can be more easily accessed, some of the top contributors to suicide deaths. So there's kind of a constellation of things that come into play. But states like ours also have a lot of protective factors that we need to really lean into. We have really strong communities. We've got great culture in our state. People love the outdoors. We have beautiful places to recreate. There's so much that makes our state strong too. So it's acknowledging some of the risk factors, but also then leaning into those strengths and looking at what kinds of things can we layer on top of what we're already doing to do better, to support people more than we are today.
And when you talk about social isolation, I mean, that is quite unfortunately, like I was talking to a buddy of mine who's involved, very heavily involved in the Cattlemen Association, former president Spencer Black, and he's been, I don't want to say outspoken, but really, really verbal about the need for people to come out and talk about their mental struggles. And he's written articles about this and he shares them with me. And I've had times when I'm like, dude, I'm going through one today. You know, like I just text him and it's like, this like all of these things lined up and I'm sitting in my car wondering like, what in the hell am I doing with my life? Like, this is crazy. But he was also telling me, completely unrelated conversation. He's like, listen, if I get home on Friday and there's, you know, he's not like a huge drinker. He's like, but if I want a beer and there's no beer, it's like an hour and a half to the store. Or like if I didn't pick up lettuce when we went shopping, like we're not having salad. Right. So because you need these wide swaths of land to engage in agricultural or ranching, you know, endeavors. So it's almost like perhaps one of the contributing factors is you need social isolation to a degree, even to be in the running to be successful in this industry.
Yeah.
What a sad proposition.
Well, the good thing is today, though, people can connect in so many different ways, right? Like maybe you live far away from your neighbors, but maybe you still get together on the weekends and you see them. Maybe you pick up the phone and text somebody. Maybe you know, like there's more we can do, and there's more we can help people remember to do. I think even people that live in cities are experiencing really high levels of social isolation these days. It's really about remembering to reach out and connect in real life and to find the people around you that you want to be part of.
When you're saying reach out and connect in real life, I have a concern about people's propensity to utilize social media as a substitute for connection, like real life connection. And it's almost like you have somebody who's starving to death. And they keep slugging down Diet Cokes. And they're like, this is sweet. It's filling my belly. Like it should be fine, but you're getting worse and worse and worse. To what degree do you think that's factoring in as well? Because when you talk about people in urbanized areas that do feel isolated, it's like, yeah, it's not because they're not surrounded by people. It's because they're not connecting to actual humans. That's right. Like even if the person you're arguing with on Facebook is in fact a human, that's a question to be determined. Even if that person is an actual human, you're not connecting with a human. You're connecting with, you know, this persona, like a caricature on the interwebs. And that largely, like I haven't seen a lot of people be so fulfilled or happy. Like nobody's ever substituted an in-person, you know, men's group for like, I just argue with somebody online, right?
No. For the last 10 years or so, when social media was new, I think a lot of people had questions about, is this okay for mental health? Is it harming us? The jury's back. It's absolutely harmful for mental health to be overly engaged in social media, especially for young people. So that's been really pretty clearly demonstrated at this point. We know that it's harming young people's brains especially, but I think for adults as well, there's probably less research and we don't know as much. We don't understand as much yet, maybe, but I think we could, you know, logically draw those connections. it's people need other people that are real, that they know, who care about them, that genuine connection. And that actually is a really good segue if I can talk about one of
Please.
our research
I'll
studies.
be quiet. Go, go, go.
No, you're good. It's just
I just get so excited.
I know. The study we did is specifically focused on follow-up care. So one of the big challenges we face in Idaho, besides some of the things we mentioned already, is that we have one of the lowest ratio of mental health care providers relative to people in need for mental health care. And so in healthcare settings, we do a lot of work to screen people who may be at risk for suicide and identify people that need support. Then, because we have these shortages, people often face long wait times before they can get in to see someone. So our research is really trying to understand what can we do when we have people that need help right away, but we don't have someone available to help them right away. What kind of support can we layer on top of that to get them help like same day, starting right away? So, and we wanted to look at something that could be done that we knew would work well, that could be done with non-clinicians. So that's one of the things that's novel about our work, is that we're looking at a type of follow-up care that historically has always been done by psycholigists or social workers. We partnered with a team of non-clinicians at the Idaho Crisis and Suicide Hotline.
Lee Flynn.
Yeah. So Lee's team.
I've had Lee on. She's fantastic.
She's great. Yeah. So her team, and she's got the most highly empathetic, deeply caring individuals who are really highly trained in suicide prevention. They know what they're doing. Talking to people at risk for suicide, including people in acute crisis, is like their bread and butter. They're so comfortable. They're not going to freak out when someone says they're not okay. So these were like the perfect partners for us for this study. So we compared two different forms of follow-up care that are delivered over 12 months. When we say follow-up care, what I mean is phone calls or text messages. So we're just, after people have left the health system, they were identified as being at risk for suicide, they go back home. We're having this team at the hotline that's following up with them for a whole year to see how they're doing. So we looked at two different follow-up models. One is called instrumental support, and that was done over the phone. When we say instrumental support, what we mean is we're like really directly focused on that person's suicide risk. So we're doing things like looking at, do you have a safety plan? Is your safety plan working for you? A safety plan is like a list of people and things you can do to distract yourself. Safe people that you can contact if you're not feeling good and you need someone to talk to. Crisis resources if things really escalate.
Go for a walk.
Exactly.
Like you have acute, very specific actions in an acute moment to calm yourself down. You have people that you can individually rely on, that you have a relationship with. Exactly. So essentially, like, what's your support community, and develop this game plan when you're in a horrible position, so that you know sober-mindedly, okay, if I'm in a bad spot, I pull the trigger on this plan.
Yes, exactly. And it's sort of rank ordered from like the easiest to do. And then if that doesn't work, then you move on to the next step, then the next step. So that you're working up and trying to intercept your suicide risk before it escalates, before things get really bad. So that's a safety plan. So that's part of the instrumental support calls, is making sure people have their safety plans. Are you using them? Is it working? Are you, okay, you broke up with your girlfriend. Let's take her off the safety plan. Who do you want to put on there instead? That kind of thing. And then we're also working on treatment engagement. So we want people to connect with long-term behavioral health care if they want it. So making sure that they have transportation to get to their appointment if it's set up, making sure they got their appointment set up in the first place, making sure they have childcare if they need that figured out. So helping them think through. And then one of the big things that came up is psychological readiness. So not everybody likes going to therapy. Not everybody has had a good experience with that in the past. So part of what our team was doing was helping people, if they were not wanting to go, helping them get to a place where maybe they would consider trying it again, and just kind of talking through what didn't work well last time and how can we find you someone that's a better fit this round. So that was really the focus of the instrumental support calls, and we did those over the first couple of weeks, and then for about 3 months for most people. And once people felt like they were all set, they had what they need, then they could stop the phone calls. Some people were like, these are great, I want to keep doing these. We had people that had like 25 calls. So we would do them as long as people wanted. But that was one of the treatment conditions. And then the other that we did is called caring contacts. This is a really interesting model that every time people hear about it, they go, that can't possibly work.
Could I ask a question?
Yes.
So, okay.
Of course.
So you guys do the study in collaboration with Lee Flynn and her organization, and plan that you guys set out, which is like, okay, the community of people that you have in your acute moment, is that something that is part of this study, or is that something that Lee Flynn was already doing with her team? Or is it something where like, okay, Lee, can you guys try to insert this strategy?
Question.
Like, because I didn't catch the part where you're like, how does that relate to Lee?
Yeah. So a safety planning intervention is something that's typically done for people at risk for suicide in healthcare settings. So before you leave the emergency department, we're going to make sure you go home with a safety plan. If you came in for a primary care visit because you've got strep throat, but you screened at risk for suicide, we're going to make sure that you go home with a safety plan if you've screened at risk for suicide. So that's something that's commonly done in healthcare settings. Sometimes patients decline, so people may go home without one. And the hotline does a lot of safety planning too. So they'll do safety plans for clients that call 988 because they're in crisis or because they're worried about someone or they're worried about themselves or they're, just emotional or upset. They're worried about suicide in the future. So the hotline does safety plans. St. Luke's does safety plans. All sorts of healthcare organizations do safety plans with patients. So in this study, we wanted to make sure that everybody got one. So if they got one at St. Luke's, great. Then the hotline team would just review that with them and make sure it was still working and didn't need to be updated. Otherwise, they would create one with them over the phone.
Gotcha.
Make sure they got a copy.
So that's going on with Lee Flynn. So what was the actual study then? What was the data you guys were drawing?
Yeah, let me describe the other. So we're comparing.
My apologies.
No, you're good. It's a comparative effectiveness study. So we're comparing these two different forms of follow-up care. One is that instrumental support I just described, and the second is called caring contacts.
Got it.
Caring contacts is delivered by text message, so two-way text that we would send out. And this is based on a model that was developed by Dr. Jerome Motto in the 1970s. He was a World War II vet, and during his time when he was deployed, there was a woman in his life that he didn't know well, but who sent him letters continually over the course of the war. And half the time he couldn't respond. He wasn't in a position to write back or send letters home. He just kept getting these letters, and they weren't like intensely personal, but he noticed how much it mattered to him that there was this one person that continued to think about him and cared about him so much that every week she was sending him these letters. So he was a psychologist. He had a lot of patients at risk for suicide that were refusing to stay in treatment. And he decided, I'm going to start sending them letters. After they've left, they don't need to stay engaged in healthcare, but I want to see. And he did research to see the impact of sending these caring letters over time. He sent them over 5 years to people, and they didn't have to reply. They could reply if they wanted to. But he found that intervention, just sending those letters, significantly reduced suicidal ideation, suicidal thoughts, and it's one of the only suicide prevention interventions that's had a big enough effect that we could measure a difference in death by suicide. So we had this really impactful intervention from the 70s. Nobody's really doing it at scale today. And so more recently, a group at a University of Washington modified this in a study they did with veterans and active duty service members to look at delivering this model of two-way contact, but by text message. So using a way we communicate more commonly today. So that's the model we wanted to compare to those phone calls I described. So we sent out 25 caring contacts text messages over a 12-month period. So these are messages.
25 per individual.
Yeah, exactly.
Like,
so each
send out 25, they're 25
random. Total. No, 25 per person in the study. Right. And the messages might say something like, hey, Matt, I hope something nice happens for you today. Just really basic. So they're not intended, like we never want to tell people, we remind them about what they're supposed to do. These are intended to be non-demanding.
Hope you brush your teeth.
Don't forget to take your medicine. Like we're not pestering them. It's not an appointment reminder. It's really intended to just be genuinely caring and to connect with that person with no agenda. They don't ever have to reply if they don't want to, or they can respond every single time and chat with us. And so we sent these messages to half of our participants, the texts, and we did the phone calls with half our participants. We enrolled a total of 797 adults with suicide risk and 723 12 to 17-year-old adolescents with suicide risk, all from St. Luke's emergency departments or primary care clinics here in Idaho.
So roughly 1,400 people from
20 in all in our state. So it's the largest suicide prevention study that's ever been done in Idaho. We're really excited about that because a lot of the research on suicide prevention comes from really different parts of the country, right? Where there are these big research universities, but states like ours are where we're really, really suffering with this issue. So we're excited to be able to do this research right here at home.
Gotcha.
For people that are struggling.
And it was text messages or phone calls.
Exactly.
Right. So you might get a phone call like, Hey, Anna, I just wanted to let you know, this is Matt. I hope something awesome happens. Like, I hope your coffee was incredible this morning.
Yeah.
Yeah. And you're like, that's it. That's all. Carry on.
Yeah. Well, that arm was, sorry, I should have said that arm was only text messages, except we did do one phone call for everybody in that group. And that was just a phone call to make sure people knew we were real people. This is not an AI trial. We're not pretending to be human.
Be bots.
Exactly.
Bots,
we wanted to like really connect with the person. And we had one person at the hotline that was your person for the whole 12 months that would be texting you. So if you spoke with Hannah or you spoke with Danny or Hannah were going to be the people that were texting you for the full 12 months.
I really appreciate this last point. There was a fictitious, sci-fi, right? A sci-fi movie that was like in the near future where people, I didn't even finish the entire thing because I was like, this movie is trash. And it's like this guy who's engaged loosely in like the military or service or something, you're not 100% sure. And he keeps getting these text messages from someone that he kind of like looks at disdainfully. And the person's like, look, man, why don't you talk to me? Like, come on. Right. And then you find out that he was in some military operation and one of his, partners or, servicemen buddies died. And what they were doing to treat his trauma around this death is they made an AI bot that was supposed to be him. So they could like work through this. And you actually see this. There was a Black Mirror episode where a mom, had her, I believe it was her husband die. And it was this super traumatic thing. And again, sometime in the future, super traumatic thing, as you can imagine, right? She's got this little kid and a friend of theirs like set up this essentially like dehydrated doll, right? So the premise is that you could get this thing that would be shipped to you. You pump water into it and it scrapes all social media and internet activity this person had and comes up with a personality, like a person that they input into the head of this thing. And the thing, inflates, but picture perfect compared to the actual person physically. And then mentally, it's who the person was essentially online used as a proxy for like how this AI thing should act. And again, both of them ended poorly because the person realized it's like, but you're dead. Like initially it scratched the itch, but then she was like, I can't, this isn't real. Like this is stymieing my progress as a person. Like I've experienced this intensely human experience, loss of a loved one, and I'm stopping myself from moving forward as a human being with other human beings because I'm trapped in my attic with you, this like inflatable doll thing. Right. Yeah. And so again, for you to say like, look, no, we are people. Like this is Danny, this is Hannah. Like this is not a bot, right? For sure. Like that's very important.
That was an important step. Yeah. We did have people, because it's a research study, people are always like, what are they actually researching? What are they really doing? I mean, we had people that would text in and say, are you a bot? Are you a robot? And
of course, the bot's going to say no.
The bot's going to say no. One of our follow-up specialists, Maggie, responded, beep, boop, boop, when somebody asked her that.
Of course, a bot would say that.
Yeah. So anyway, but our team, I mean, I really can't emphasize Matt Biss and his team at the hotline did such an incredible job of letting people feel that genuine care and connection from them. I like that team is just so deeply caring about every single person that was in this study. And I think our participants really experienced that. So
once the text got out, if the person responded, would they engage in a conversation? They're like, no, I'm going to text you again in 2 weeks. No. Like, I just hope your coffee was good.
No, they'd respond right away. So we made sure that we sent the messages out when we were in the office and able to review, incoming messages and respond and text back and forth with people. We also had our team make sure that participants knew when they would generally be able to see texts because they're real people. They're not up all night, right? They don't work 24/7.
Right.
So they would give them these are the hours I'm at work when I'll probably see your messages. You can text me anytime. And we did find that some people would text in at like 11 p.m. and be like, I know you're not going to see this till tomorrow, but I just need to get this off my chest. And would send us like 5 paragraphs of text and then say, I feel so much better. Thank you for listening. Right. Even though they knew their person wouldn't see it till the next day or maybe after the weekend was over. So,
dude, that's okay. Before I go off track again. So what happened? 1,520 people.
Yeah.
You have these 2 models. One is, hey, let's do a crisis plan and like have that out. And one is, we're going to connect you to the human beings again. Even in a limited and imperfect a way as possible, we're going to do this. And this was essentially an A/B test.
Exactly.
What happened?
Yeah. So we were comparing those two conditions. We followed people for 12 months. We collected data at baseline and then again at 6 and 12 months, really focused on their suicide risk. We also asked about loneliness. Are you getting mental health treatment? Have you used the emergency department recently? Those were kind of our 4 key outcomes we wanted to look at. What we found at the end of the study was super interesting. So our results were different for adolescents. Well, first thing I should say is both treatments worked really well for everyone.
Correct.
Right. So we were not comparing this to a null or like a placebo condition. Other studies have done that. Both of these treatments have been proven to reduce suicidal behavior by about half. But this is the first time they've ever been directly compared to see which one works best. Like we know we have 2 really good things. Which one of those is the very best and for whom is it the very best? So one of the cool things we learned is that for adolescents, we found that at 6 months, there was no difference and both were equally effective. But when you looked at 12 months, the lines started to diverge. And the adolescents that were receiving the caring contacts text messages were doing significantly better than the ones that were getting the phone calls. So overall, we saw in the last 6 months of the study, 2.5 times fewer people, adolescent participants reporting suicide attempts if they were getting the caring contacts text versus if they were getting the phone calls.
And the phone calls were the plan?
Everybody got a safety plan. The phone calls were to check in, see how you're doing. Are you using your safety plan? Are you getting to treatment? Do you need any support with anything?
Understood.
They were still really caring. I mean, I feel like I have to emphasize that too. These phone calls were the same people doing the text messages. Like they cannot not care about a person.
Sure.
We kept being like, you have to keep the phone calls shorter. Focus on that. Like they're going to listen. They're going to talk to them. Like, so they were a lot of connection in that treatment condition as well. But the text messages really did work better in teens, we found, especially in the second half of the study. And then when we looked at our adult results, we found that the phone calls actually worked slightly better in the adults than the text messages at the first 6-month time point. By 12 months, the 2 treatments were working equally well. So again, both of them worked well for everybody, but adults seem to benefit from either the phone connection, like the connection of actually speaking with someone, or it may have been the content of those calls, like really helping them focus on problem solving and getting resources. And like maybe that piece is important for adults. If you think about with adolescents, the adults in their life are probably dealing with most of that stuff for them. So for adolescents, they really just need that connection and that long-term connection over the full 12 months.
Yeah. And again, my apology. I misunderstood that it was like one group we're giving a plan to and the other group is getting some communication. That's not the study. The study was everybody gets the plan, but then we follow up either via phone call or text message 25 times over the course of this year. And
the phone calls were not 25. The phone calls were generally 6. Some people got 1. Some people got way more than that. We let people get kind of as many phone calls as they needed. Those were more concentrated in the first 3 months of follow-up.
I am not surprised by, like, I don't know anything about adults. I'm barely an adult, but the teenagers responding better, especially higher frequency, less investment.
Yes.
Less investment as in temporal investment, so I don't have to pick up right away. Less emotional investment, like I can get control of myself and respond whenever I want. Like you can also send text messages to somebody and you have high confidence that they'll get it and they'll respond in the morning. Like all of these different things, and it's how they communicate. Like even it's far easier for me to engage in something like this where like I might text somebody and be like, today is a damn dumpster fire on a nuclear bomb going into a volcano. And like, that's it. And I don't want to be, I need to blow off like 10 seconds of steam. I don't want to be on the phone with somebody because then, especially if they don't pick up, then it's like they'll call back later or like, did you call? I'm like, oh yeah. Like the moment's lost, right? Whereas the text message allows me to get this thing out and experience, boom, it's just gone like, and you know, especially for people that utilize that, I could totally see that.
I feel like you articulated that so well. The other thing I think for adolescents, sometimes they don't want their parents to know how they're doing, but they need to talk to someone. And if they're in their room, someone can
Who you on the phone with?
Exactly. So it's a much more discreet way to reach out for help.
Right.
I'll share one story of a participant. This was a young man in one of our rural communities who he had a history of a lot of suicide attempts and was very high risk. His parents knew he had a really supportive family. They made a lot of effort to make sure he got the care he needed, but part of that, he felt like he was a burden to his family. He felt like he didn't want to bother them every time he was feeling suicidal because they did so much for him already, and he knew how much, how hard it was for them. So
that's almost exactly what the young woman I worked with said.
Yeah.
She felt
it's a
like
really
this enormous
common
burden.
that feeling of burdensomeness is one of the kind of hallmarks of folks that are struggling with suicidal ideation often experience that feeling. So this young man was having a particularly difficult day and was preparing for a suicide attempt. And he reached out to Matt, his follow-up specialist, and just said, Matt, I don't feel safe, but I don't want to tell anyone. But he told Matt. And that was enough for Matt immediately, his radar went off and he knew he was concerned about this person. And so he spent probably an hour and a half texting back and forth with him. He and the participant agreed that he really needed to tell his parents to be able to stay safe that night. But he just could not bring himself to do it. And so Matt finally said, if it's too hard for you to talk to your mom, what if I talk to her? What if I call you and you pass the phone to her? So he immediately agreed to that. He was like, that would be amazing. Thank you so much. So they just put the phone on speakerphone and Matt helped facilitate that conversation with his mom. The kid was like immediately relieved that he'd told his mom. He felt so much better. The mom was like on it, ready to take care of her kid. And so like, what a good outcome. But that's a kid that was in a place where he maybe wouldn't have been able to pick up the phone and call 988 to talk to a stranger. But he was able to text back to Matt.
A person.
Someone he already knew, who knew him, who he trusted, who he knew wouldn't freak out and call the cops the first thing, if he said he was struggling with suicidal thoughts. So there's a lot of power in this model because of the trust that you develop and that relationship you develop over time. And one of the things that's cool about this is the first time that we've done it with, it's scalable. Like you can do it. We were able to support 1,500 people who needed a lot of support, but with a small team of like 5 or 6 people. So this is something you can do without saying, well, we don't have enough clinicians. We don't have enough. Like the cool thing is that you can do it in states like ours. You can do it in rural areas where there aren't a lot of resources. So.
Yeah, and it just doesn't take that much.
It doesn't. It's like being available at the right time and bringing that resource to people when they need it.
I text people a lot, and I text people a lot and start with like, you don't reply, right? And a large part of that is things are really hard, right? And I meet a lot of people, and I meet a lot of people working really hard, and I meet a lot of people working really hard that have thankless, just grinding endeavors, and I don't, a very dear friend of mine, Dave, once told me, we were driving home we were training jujitsu or something. We like went in and out, and then he was driving me back home, and he swung around. I was like, why are you turning around? And he was like, oh, that person's like stalled out or something. Right. And it was like 10 o'clock at night or something. I'm like, Dave, we can't be stopping to like help people. And he's like, no, man, we should stop and help this person. Right. And so like we pushed the car because the battery had died or something, and, got her out of the middle of the road. And he just said in passing, he's like, look, man, never hesitate on a kind impulse. And he told me that when I was like in my early 30s. And
so nice.
Yeah, man, that stuck with me. It's clung to me like fungus that I like, and not that I would ever want to be rid of it, but it changed the way I view little things for people. And I like hearing that this is the experience people have. It's like, what if everybody just did this for each other?
Totally.
Like what if people just started firing it? Like it doesn't take long. It's like, hey, Brian, right? Like don't respond, man. I saw that thing you did. Awesome. Or like, I hope that thing you were in is like resolved. Like whatever it is, you don't even need to tell me. God bless it,
just
man. Get out. Just something.
I care about you.
Like, totally. And I even stopped over COVID. I even stopped writing things. I would just start sending like hearts to people just to let them know I was thinking about them. And they would send like a heart back. And it's like a little emotional exchange. And it's like, it's so little.
So powerful.
So I know. Yes.
Yeah.
And it takes so little.
Yeah.
It just takes people not hesitating and then thinking, well, what if it's not
I
the
don't wanna
right
bother
dude,
someone.
How about
Yeah.
how about the conflict of what kind of heart do you send? Do you send the purple heart? Do you send the red
What
heart?
color?
What color?
I really
Like,
overuse the sparkle heart.
right? But it's almost like with okay, so I had this really funny podcast years ago about emojis becoming a different form of communication because you have a laughing face in like 25 different iterations and all of them mean different things, right? Are you laughing at the person? Are you laughing with the person? Are you like all of these different things? The hearts are the same thing. And it seems that the single red heart is reserved for somebody who you're intimately involved with. A double red heart could mean like something different than the purple heart, than the sparkly heart, than like a heart, GIF. Like all of these things mean different. And it's like, well, I don't want the person to misunderstand.
Yeah.
I'm not like trying to.
Yeah.
And instead of getting into that, I just send only the red heart.
Yeah.
So it's like, I send this to everyone.
It goes to everyone.
Yeah.
That's your standard. Yes.
Yeah.
Yeah.
But talking about a profound thing that is scalable and is something that a community can act on.
Yeah.
Like that's one of the biggest things. If the community is recognized, just this simple act.
Just do this for a couple people in your life, like a couple people you care about, and maybe some people that you've lost touch with or that you know are having a hard time. And some of the key things to remember are don't expect anything in return. Just send that nice thought out there to them. Do it repeatedly over time. Right. So it's not a one-off. That's not usually enough to that still is helpful. That's still super nice to receive. But like, if you really want to make a difference,
you have a multiplier
over
effect.
time, it really matters to let people know. I think about you and I think about you often. It matters. You matter to me. Yeah.
So once you got this data back, obviously it's like, okay, look, the teen structure or the teen susceptibility to positive influence in this way. Is likely the highest ROI we could get.
Yeah.
Because this is something that, like, to call somebody, again, the problems with teens in particular is to call people like who you're on the phone with, what's going on.
Yeah.
Like, I have anxiety around calling people.
Know.
I never call people.
A lot of our teens didn't like the phone call. I mean, I shouldn't say that. We had a lot of positive experiences in the phone call arm for both adults and teens, but we also had a lot of teens that are like, could we please just do this over text? So they're just more comfortable as a generation with text messages, and it's so much more scalable than the phone calls, and both of them worked well. Like that's the big takeaway is both worked really well. Both reduced suicide risk by about half. So we know we've got two really good models and we know how to layer them. Like really what we would recommend at kind of a public health level is for anyone with suicide risk, we should be sending these text messages out. And then if we can layer in some additional instrumental support calls for the adults or people that are extra high risk, that's worth the extra lift, when you can do it. So
is there discussion of attempting to communicate the importance of this to like high school populations, right? Where it's like, okay, self-rescue, right? Like we are here for you guys 100%, like everybody is, but this is also something that all of you can engage in.
You can do for each other.
You can do for each other. And it's...
I love that question. Because we've thought a lot about how could we get this in place systematically so that teens are getting texted, so that teens are benefiting. But I love the question of how do you inform teens of the power of this kind of communication so they can help themselves? I think that's such a cool idea.
Yeah, dude, that has to be... Like we all
want
want
the solution. We don't need to just fix it for
right. And we all want to be everything for everyone, right? But we're just not, and we just can't be. And the people that teens spend the most time around are their peers, and their peers are also most likely to be empathetic and understand the situation and frustrations and everything. And it is one of those things where it's like this community in particular is at risk in a manner that it hasn't been in times past. Like horrible, horrible instances of, for instance, young men taking their lives when they're sextorted, right? And they freak out. And you have like the captain of the football team or just an average teen that's quiet and nothing noteworthy gets sucked into this scam and goes from first contact with the scammer to taking their lives within 1 hour, right? If there was a plan where it's like, listen, you need to text somebody, just like have a secret emoji that only one person knows or two people know or three people know. And it's like, if that emoji goes out, they stop everything and call you and talk you off this ledge, because the shame and anxiety that people experience is so profound. It's like the idea of calling somebody or let alone telling your parents, right? Like, that's a really dark thing. But if you have a community that then supports each other and recognizes we're all fallible, it's like, listen, if you get into a bad spot, I don't care what you were looking at or what that person sent you or what you sent them. Like, you text me the purple pineapple. I don't know, whatever it is. Like,
yeah.
Is there any like discussion on how to is there a campaign brewing, or is there an idea of like, okay, who does like the school interactions at St. Luke's or whatever? It's like, okay, is there a campaign coming to fruition?
Well, let me tell you about a couple things. One, I'll tell you about kind of what we're doing with the results of this trial, the Spark trial that I just walked through. And then I want to tell you about the Bright trial, which is a new school-based suicide prevention project that we just got a big research grant for. We're super excited about. So let me start with kind of what we're doing with the results I just described. So we've done a lot of presenting we've presented 10 times at national conferences to try to get the word out beyond our state so that folks are talking about this, are aware that these are really feasible interventions you can deliver. And then we also put together a 63-page implementation toolkit. Sounds like a lot of detail on how to send text messages, but there are like operational complexities behind it. Like, how do you set up a legal agreement between a health system and a suicide prevention hotline to be able to do this work and share patient information, which has to be private and secure? What's the technology platform you use to keep everything secure? How do you manage that volume of texts from that number of people with so few staff? And what are the ideal staffing ratios? We've got all that kinds of stuff in this toolkit that we launched this fall. And so we've been getting that out to other 988 hotlines around the US. And we have a couple of states we're working with, including Maine, Colorado, just a couple different states that are really interested and are trying to. Maine is now already standing up a program of their own to do this kind of follow-up care for their clients. So we're really excited about that. We're really proud of that. We're working really hard at St. Luke's too to design a program for all our patients that we do a lot of screening for suicide risk in healthcare. And our patients that screen at risk for suicide, we would love for them to have access to this kind of program outside of a research study so that they're getting this care and this just becomes like usual care that we do for everybody that needs it. So we're working on that in the background too. So yeah, trying to get the word out, trying to put out practical tools that make it so other folks can do this themselves and learn from, our 6 years of work. They can take that and run with it. And then we're also thinking about what are the remaining research questions that are out there. So one of the big questions we have around carrying contacts, the text messages, is in practice, the health systems that are using carrying contacts are generally sending out one-way texts. So they'll send the nice text messages out, but they don't have staff to monitor and respond to incoming messages. So they're just one way.
Right.
So we're in the middle of a study right now that will wrap in February. We'll have results soon, and maybe I can come back and share those when we have them.
I would love that.
But we're comparing one-way texting versus two-way texting versus best available usual care for people at risk for suicide to see, does having that back and forth interaction really enhance this intervention? My strong suspicion is that it probably does, because of things like that story I shared where you get a lot more than just the caring contact. You also get kind of on-demand support to help work through a crisis. And I should make the point too, a lot of the text messages we got back were people having a great day and doing fine. Just because someone's had suicide risk doesn't mean they're going to feel suicidal every day for the next year. A lot of people recover. And so we had the pleasure of a whole bunch of pet photos, a whole bunch of like, here's my quilting project, here's my woodworking project, like people just sharing what's going on in their life and connecting. And then the people that did experience crisis, our team at the hotline is obviously really, really good at helping them manage that and stay safe.
Yeah, man. I would love to understand what those results are. Here's a question for you, and a weird situation we find ourselves in. Obviously, we have a recent parental consent law that got put in a few years back, and there are holes in it. And one of those holes is this kind of thing where you have, if somebody's at a point of suicide, a minor, and they call on the hotline, Lee Flynn's team at Suicide Crisis, can address that acute situation, but they're not allowed without parental consent to engage in any kind of follow-up or additional care, right? It has to be like this person's life at risk. Okay. And by the way, I understand the sentiment of the law. Like I don't want anybody doing anything with my kid without my consent, but there are these holes, especially in some of the darker instances, somebody that might be accusing or saying like somebody that did get hurt by a family member that would, that the family member would have to consent for them to be talking to this person. It's like, well, they're probably not going to consent because they're, the perpetrator. Anyway, I have to imagine that this type of engagement requires, especially for minors, parental participation.
It does. Yeah. So any kind of research study requires parental consent and the minor's assent. So both of them, we want to be fully informed. It's always optional. You never have to be part of research. So research, that's easy. When you move to a program longer term, we still, in order to contact people long term, we would need their consent from an adult and the consent of a parent for a minor as well. As the minor's assent. So we always want to make sure people want us to be reaching out to them. We're not trying to spam them or,
100%. And you also, is there any discussion from, perhaps skeptical but participatory parents like, hey, are you going to log what is said back and forth between these people?
Well, one of the questions parents sometimes want to know, are you going to tell me what you're talking about? Are you going to loop me in? And for this study, the way we handled that is we explained to parents at the beginning, if your child's suicide risk escalates, we will always let you know that. We want you to be informed so that you can help keep your kids safe. So if they've taken a survey and they're higher risk than they were last time, we're going to let you know right away. If your child discloses other details about drug use or other things that may be personal and private, those are not things we're going to share. So we make it really, really clear. And that's part of agreeing to be part of the study. We collect a lot of information from your kid. The part that we'll share with you is related to their safety. So parents know that before they sign their kid up and agree to that.
So it's kind of like a standard kind of like counselor agreement.
Yeah. Pretty similar to lots of other kinds of care. You're right.
Gotcha. Okay. So what's the grant?
Okay. The grant we're super excited about. It is not a good moment in history to try to get a research grant.
Not a great time for grants.
We're pretty happy about this one. This is kind of our dream study. So this is another what's called comparative effectiveness study. Part of the reason I love this kind of research is that we're not experimenting on people. We're not doing things that might or might not work. This is such a serious area of research and such a serious health issue that you want to be really careful. And I love doing research that involves comparing two really good things that wouldn't be available otherwise. So everything we're doing is adding resources. It's adding extra care for people that they wouldn't receive if we weren't doing the research. So in this case, it's a school-based project. We'll be partnering with schools and school districts around Idaho to compare the two suicide prevention programs for schools that have been proven to reduce suicide attempts in kids. So we focused on those two programs specifically because they have the best evidence behind them.
Sure.
And we want to see, okay, these are the best we know of today. Which one works best in Idaho? And is one better in 8th graders and one's better in 10th graders? Should you do one sooner? Is it better to layer the two together? Do actually the kids need to get both? And let's set one up for junior high and one up for high school. And that's ideal. And if so, does it matter which order they get them in? So those are the kinds of questions we'll be able to answer. We're doing this work in partnership. I'll be co-leading it with a researcher out in Ohio at Nationwide Children's Hospital. And St. Luke's is co-leading with them. And then we're also partnering with University of Washington and University of North Carolina at Chapel Hill. So we'll have 4 different states, pretty different states: Ohio, Idaho, North Carolina, Washington. Part of the reason we did that is we want a really diverse sample. We'll have about 7,000 kids enrolled in the study between the ages of generally 14 to 16, so 8th to 10th graders. And we'll follow them for up to 2 years to collect data on their suicide risk. And schools will deliver one of these two programs that have been proven to be really effective. The two programs are called Signs of Suicide, or SOS, not to be confused with the other SOS, School-Based Suicide Prevention Sources of Strength. I don't know why we keep naming everything the same thing. It's the other SOS.
Can I tell you something really fast?
Yeah.
So I have a nonprofit. It's called Truth and Media Foundation. Okay.
Okay.
Now, at the time when I incorporated as a nonprofit, like I filed, I believe, in the end of 2024. And I was like, is there any other Truth in Media Foundation nonprofit? And they were like, Rocket Lawyer said no. And I was like, great, Rocket Lawyer, no problem. So I go ahead and make the nonprofit. So it's like, because I'm doing work and maybe I could get grants or whatever. Like, I have no idea how it works.
Yeah.
Turns out later on, two things in particular. One, as 2025 develops and more people become familiar with the show, I obviously, not everybody's always happy about the shows I do. So people start digging and they're like, Truth in Media of Virginia. This is a Russian operative, because apparently there's a Truth in Media nonprofit in Virginia that was incorporated in 2019. When I didn't even live in the state of Idaho and was happily SAT tutoring in the state that shall not be named. And people were like, oh my God, his board members are Russians, which is apparently true. And they're like, he's a Russian plant, which was hilarious. And then that one's a little silly, but the other one is that apparently since I did this, somebody came up with the idea of Truth in Media for like a super hardcore right-wing cray-cray. So it's like super inflammatory, super right-wing stuff. And they got like truthinmedia.com.
Okay.
So sometimes guests come in and they're like, well, I
Googled
don't
you.
appreciate all the stuff your organization, like I like you, but your organization, I'm like, wait, I am the organization. Like, what do you mean? They're like, well, all that other stuff you post. I'm like, what other stuff? Like, I personally make all of it. So now we're going to have to like change the name. So we're going to have to change because we're like, I can't be associated with like some crazy truthinmedia.com that's like this right-wing fever dream, like crazy people. I don't know that it's all crazy. Some of the stuff I've seen like, wow, that's really out there. At least it seems that way. And it's not in Idaho. It has nothing to do with me. So like, yeah, naming is a problem.
Yeah. It can get very confusing.
Yeah, I'm going to have to change it to like the Ranch Podcast Foundation or something. It's like there's no one else that's doing the Ranch Podcast. Yeah. Anyway, I'm sorry, keep going.
Oh, you're good. So there are two different programs we're going to be comparing, the two most effective, Signs of Suicide and Youth Aware of Mental Health, or YAM. So the Signs of Suicide SOS program is a little bit briefer. It's over 2 classroom settings. Both of these programs are delivered in schools, like during a health class, for example. So during a normal classroom period, not like a separate assembly, not a pullout, just like embedded in the normal curriculum for the school. So Signs of Suicide teaches kids the acronym ACT, which is, oh boy, hang on a second. I have to redo this take. What does ACT stand for? ACT. It's like a care and tell a trusted adult. What's the first one? Acknowledge. Okay, I got it.
Okay.
So the SOS program teaches students the acronym ACT, which involves acknowledging that there's a problem. So that means someone around you is struggling with suicide risk. The first thing it teaches you is how to have that conversation, not to shy away from conversations about suicide or about depression. Or
sweep it under the rug.
Exactly.
Like,
acknowledge
they're
it.
just a little sad today.
Exactly. You don't want to ignore that. If you feel like you're seeing something or sensing something, it's okay to acknowledge that. It's okay to ask directly. Those are all helpful things to do. Asking about suicide does not make people suicidal. It does not make things worse. It makes things better for people. So that's like one myth that they work really hard to dispel. Secondly, you want to care. So genuinely connect with that person and let them know you care about how they're doing. It means a lot to you that they shared that with you. You're glad they told you. And then T is to tell a trusted adult. So we're not trying to get teens to manage suicidal crises on their own. That's never the goal. But we know that teens tell each other how they're doing. And so we want them then to have a trusted adult that they're ready to loop in, that they can tell. Part of the SOS program involves some optional trainings that are available for teachers and staff in the schools, and also parents that are interested, so that your trusted adults are then also getting trained up so that they can do a better job supporting the teens. So that program has been shown to cut suicide attempts in about half. So you'll have about half as many suicide attempts if you implement that in a school. So that's one of the really good programs.
Can I say something?
Yeah.
Like, what?
Why are we not already doing this everywhere?
No. I'm with that. I understand these things are complex, and there are varying degrees of need throughout different communities, different areas. There are varying degrees of resources. There's scope creep, right? Where it's like, you're some public school administrator or teacher, you're like, okay, here we go, another program. Like, you have all of these problems. But that aside, you like, what a difficult proposition that you're like, look, we aren't going to be able to stop kids from attempting suicide.
Mm-hmm.
What we can do is help.
Mm-hmm.
But we understand we're going up against an impossible task of preventing loss of life.
Mm-hmm.
But we are going to try, and we're going to try to find the most successful, but that's not going to stop the difficulty of life.
Mm-hmm.
And it's not going to stop, to whatever degree it affects it, mental illness.
Mm-hmm.
It's not going to stop, God forbid. Oh my gosh. I was coming out of my elementary, but it was a couple of years ago. I picked up my kid. And man, there was this like yellow IROC that stalled out in the middle of the road, right? And there was a center like turn lane, so it was like in the middle of the road. But we were like, oh, and it's like a yellow like IROC from back in the day, right? And not like some beautiful, well-kept vehicle. So my wife and I see this and pull around the corner, and I run over, I'm like, hey, can I give you a push? And this, I presume mom is there with her, like second or third grader daughter. And she's like, I'm trying to call my husband, like my phone's dead. Could you call? So like I get her a piece of paper. I'm like, write the number. I'll call or text this phone. And she was like, great. And, gets all the info. And here's this girl with this backpack, like little kid's backpack. And I'm talking to them through the window, and it's like the inside panelings on the car are gone, right? Like the car is in horrible shape. It's not starting. And it's, like I text this dude, I call, he doesn't pick up. And then I text him. I'm like, hey, this is where, your wife's at and your daughter's. Text me back. I'm on the way. And we waited, for a little bit just to make sure they were okay. But like, I don't know what that family was going through, or that woman and her child, or the dude. Like, I don't know what they were going through, but I remember like it broke my heart, because it's like, here's this person who's just trying to pick up her kid, and it appears that she's even incapable of securing safe transportation and consistent transportation for this child, and it breaks my heart, right? Like and you was like, you would want to do something, but it's like, what do you do? Life is hard. Like, things are difficult. We're all dealt different hands. We're all dealt different situations where we have our own demons we're like struggling with. And then we have little people along the way as we're like going through this mess. And it's like, in spite of all of this, yeah, you can try, but don't kid yourself. Like, you're never going to fix that. What you could do is maybe do something that prevents people from acting in the worst way in their worst moment. And it's what a hard task to even take on.
It is hard. You're totally right. No, but so the one thing I would caveat that with is doing a school-based universal suicide prevention is one of the things we should be doing in our community. If we're doing that, and then we're also layering in caring contacts, and we also have therapists that are treating kids that need support, and we also have parents that know how to support their families, and we all, there's never going to be one thing that will be 100%, especially for something as complex as suicide. But when we layer on multiple effective interventions together, they become really powerful. So I think that's the kind of hopeful takeaway, is that we have more than one tool in our toolkit. There's more than one thing we can be doing, and there's more than one thing we need to be doing to help our communities be more robust and more prepared to support adults and kids that are struggling.
So the SOS with the ACT, the acronym that shall not be named,
yes.
is one, and that's been shown to decrease suicide attempts by 50% within school communities.
Yeah. So there have been a couple studies. They range from 40% to 60% reductions in suicide attempts. And then the other program that we're looking at is Youth Aware of Mental Health, which is YAM. It has one really, really large trial behind it that shows that it reduced suicide attempts by about half. And so you can see the two programs are pretty comparable, but they've never been directly compared to see which one works best. And they've never been compared in Idaho or any of these other states. So we're really excited about doing that. Youth Aware of Mental Health is a youth-driven program. It's very discussion-oriented. It is delivered over 5 days instead of 2 days, so 5 classroom settings or sessions. And It really focuses on empathy building and perspective taking and teaching youth. It's more broadly focused on mental health. Signs of Suicide is really pretty specifically focused on depression and suicide. Youth Aware of Mental Health is broader than that, so it'll touch on lots of different mental health themes. Both programs are trying to reduce stigma, make it easier to talk about this stuff, help kids learn to connect with one another on this, and to bring in trusted adults. So ultimately, we have two really good programs, but neither of these programs are being delivered right now in Idaho, with the exception of Signs of Suicide. Boise School District just started that last year. So we've got a little bit of that, but otherwise these will be new programs to our state. And that's one of the things I'm most excited about, is just bringing these really good supports to our state and training up a whole bunch of people that will be able to continue to train after the grant goes away, getting our schools stood up to be able to continue this work long term.
Yeah, man. Man, the world is a tough place.
Mm-hmm.
That's a really, I'm reminded of that daily.
Mm-hmm. Yeah.
But,
it can be. But I will say, as someone that works in this space all the time, so much of what we see is people struggling, but the people are really resilient, and just about everybody recovers. And we have so many stories of hope and recovery that come out of doing this work, because people ask me all the time, is this a really tough field to work in? In some ways, yes, but I feel so inspired, and I know my team feels the same way. I've got this amazing team of research coordinators that support this work day in and day out too, plus Matt and his team at the hotline. And I think we all find this work deeply inspiring, because we see people that have really gone through stuff, like the woman with the car you just described. I've never experienced that. I hope I never do. You don't wish that on anyone, but like, people really do go through stuff, but with a little bit of support, a little bit of extra, layering something in schools that teaches all students how to take care of each other, giving people small reminders, little text messages that I'm here for you, I care about you, you matter. Sometimes that's enough for people to bounce back and recover. And so layering those on top of all the other good resources we have in our communities can be really, really powerful.
I think, I think a lot about my kids. I have 3 boys, and the world they're going into is not a forgiving one. Not that the world has ever been forgiving, right? Not like we live in the most advanced, incredible time ever, but that doesn't mean that there aren't, predators around every corner trying to get them, right? International predators. We have all kinds of international instability and national, anxieties, like all of these things. And I used to have this joke with my SAT kids that are like, you realize your parents didn't have you because they thought you'd have a great time here. And they're like, what do you mean? I'm like, what's the first thing a mom does when she has a baby? Like, get away from my baby, my baby. Like, she doesn't have you and look at you and say like, oh my God, you're going to have the best life ever, little baby. You're never going to experience anything. No, they instantly are like, somebody's trying to take my baby, because they know that the world is this crazy place, right? Like the real line when, your parents only had you because your mom wanted a dog and your dad wanted something else, and 9 months later they had you, right? But like, you have this horrible realization that's like, God, man, I want to protect you from all of the pain, like all of the terrible things, all of the things that are drawing us and sapping our life away. And I had this conversation last week with somebody about the need that young men have to help them navigate the unlimited supply of online pornography and how horrible that is for young men. And like all of these things, right? And in thinking about the things you're talking about, it's like, look, you want to grab these young people and hold them and like help them. And like, I will make the world better for you. Like, I will pave the way for you. But the real answer is, I'm going to help arm you with what you need so you can go forth and not fall back into this, because I can't do it for you. You have your own life to live. You're going to have your own struggles and your own pains. And damn it, I wish I could make the world different, but I can't. But the thing I can do is help you be strong enough in your moments to not succumb to this, because that's what you really need. And it's just, man, it's wonderful to hear that you guys are doing this. It's just such a stark reminder that it's like, yeah, man, you have to be tough. You're going to have to be really tough, and you're either going to get sick and die young, as I've had many friends do, or you're going to live to an old age and watch all your friends die. There's no way out of this. It is going to be hard no matter what, but damn it, man. You have to be tough enough to get through it and hopefully contribute something to the world along the way. Like, what a horrible proposition.
Well, I think what we're learning as we go through all, research study after research study after research study, we're learning that some of the tools that are the most powerful are the simplest. Yeah. They're things we already have. We're looking for these solutions sometimes that are overly complex, when really what people are missing and what people need is that reconnection with somebody that cares about them.
You need people.
They need to know how to talk about suicide. They need to know how to tell a parent. We need parents to know not to freak out and to listen. And I mean, take it seriously. That's not the message. It's always serious, but also try not to panic. Try to let your kid know you're glad they told you. And then, reach out to 988 or reach out to your primary care provider, your family medicine doc, someone who can help you navigate and figure out what the best next step is. But just having the conversations, removing that stigma. I will say one thing that is super hopeful to me is our younger generations are so much more comfortable than we are talking about mental health.
Yeah.
That's amazing. That's like a really, really big strength. And I think our job is just to continue learning about this and do what we can, like you said, to give people the tools that they need to stay safe and to stay happy and to have good, productive lives.
Yeah, parents not freaking out.
Yeah. Good luck with that, right?
Good luck.
As a parent.
Did you...
Easy to say, not easy to do.
You have kids.
Yes.
Did you ever hear any of the... a lot of psychoanalysis comes out constantly, and you're constantly bombarded with it as a new parent, right? And you're like trying to change diapers, and they're like, well, and like take care of these kids. And one of them that I heard was so great that when you're changing a diaper with a lot of number 2 and it's not great in it, when you're changing this diaper, you have to smile and be happy, because if you recoil, if the baby's staring up at you and you open the diaper and you recoil, then they'll get a complex around their genitalia because they think you're horrified by their genitalia. And I was like, you want me to smile when it's done?
You just gotta sing a song about whatever you see in there, right?
Oh,
keep it positive.
God. Can I tell you something hilarious? So I have 3 boys. When we had the second one, first kid, as you know, it's like, first kid is like a hobby. I don't mean to belittle it, but like I would pick up my kid and like a football, like I just grab him like this and just wander around with him. And he would be, I grab his thigh, so his head's here and his little belly's there, and I just wander around the house with him, right? Like no problem. He was just attached to me. He was like, great, it's no problem. Kid 2 is a little crazy, right? So we have kid 2, and it's like the 3rd day the kid is back home. And, we're introducing him to his brother, and we're like going through all these things, right? And of course, neglecting ourselves because we haven't eaten. Yeah. So like finally, like we make dinner, and it's like a Tuesday or something. We make dinner. It's like 8:00, make dinner. Of course, the dinner gets cold. And then by like 10:30, we're like, okay, look, got everybody down. Got everyone down. Let's do this. Let's get him changed, the newborn. Let's get the newborn changed. It's going to be fine. We'll change him. You'll nurse him. He'll go right to bed. We'll sit down and we will eat, and it will be glorious. And my wife's like, okay, great. Here we go. She was like, okay, I'm just going to change him real fast. I'm like, okay, great. I'm going to go get the stuff in the microwave. She, in spite of our protocol, standard operating procedure, is just like, okay, I'm just going to change him on the bed real fast, right?
Oh, no.
Opens the diaper, and I kid you not, within a second, projectile everywhere on our bed, on the headboard, on the foods in the microwave, and just like envision 2 parents just staring there looking at this and hearing the beeping of the microwave in the background because the food's ready, and knowing you're like, we're in it for like 3 more hours of laundry, everything else. God. Man, kids are crazy.
The early days, yes.
Oh, what a thing, man. Yeah, you better rally, because here we go. God bless it. Anna, thank you for coming in today.
You're like, welcome. Thank you so much for your time.
Of course. come back in February when you get the results of the thing you're doing.
Yeah.
I would love to hear how this goes. I'd love to hear the results of your grant and everything else, the A/B testing. If there's anything I can do to help, get these things integrated into, the state. I'm actually interviewing the superintendent of ed next week.
Oh, nice.
So if there's like whatever it is, I'm a nobody, but I happen for some reason know a lot of people.
Thank you.
So if there's anything I can do to help, please let me know. Cause like, damn it, man, like this is just one of the most fundamental things. Like talk about a failed society if we can't keep our own children safe from themselves. Like we need to reorient ourselves and get back on track here.
Amen.
Perfect. Well, thank you for coming and we'll do it again.
Thank you too.